It's always a good thing when your board member says such nice things about you. Thanks, Rich. I'd like to get a sense of who's in the room. Just kind of how many physicians are here? And of that, how many of you are in palliative care or palliative medicine? Okay. And how many nurses? About the same amount. And social workers? I'm not sure what other categories. What if chaplains and people? Oh, great. How many of you are working in hospice? And how many of you are working in healthcare systems that might be able to become learning health systems? Okay, very good. Great. Thanks for introducing yourselves to me. I wanted to start by telling you a little bit about where I come from and inviting you to come and visit. The Hastings Center is the nation's first bioethics institute, and many of the people that run bioethics centers around the country got their start at the Hastings Center. We have a staff of 25. 7 are full-time scholars doing their own original research, and we publish 2 journals, the Hastings Center Report and IRB, which is a more niche journal that's focused on people who are charged with protecting human research participants. A lot of the dialogue that has been around the ethical oversight of learning health systems has been on the pages of those 2 journals. If you ever find yourself traveling east, you have an open invitation. We even have apartments for visiting scholars, and we love to have company. And you will be in store for a great treat because we are located in the central Hudson River Valley, along one of the most beautiful train rides in the United States, only an hour north of Manhattan. So come and visit us. Now, don't be angry with me. This is the view from my office. And as I say, we have an open door, so come and share the view with me. I'm going to speak for about 15 minutes right now at a pretty aerial level about what learning health systems are and trying to make the case that Rich set up for me. You know, why is there a moral imperative to become a learning health system? What is it, and why is it important to become one? And then this afternoon, I've been given a longer period of time to kind of delve more into the details of what the issues are. Why is it problematic and uncertain right now how ethical oversight of this new transforming learning health system, why is it that there are some questions about how to manage its ethical oversight? So I'll go into more detail later. But this morning, it's the big picture. And the big picture is that unlike other sectors of society, like the airline industry or the auto industry, the healthcare industry has been much slower to come to safety and improvement. It's catching up, but it's certainly been much slower and later to the start. And also, as a consequence, our medical education of young physicians, especially in training, relies on a cultural narrative that is focused most on helping them develop a professional attitude focused on the fiduciary relationship to the individual patient. Of course, that's the core of a healing profession. And we have to nurture that during the socialization process that physicians go through as they're being trained. But we have to also expand what happens during that training to focus on at least 2 things: on a more systems orientation, so that there really are obligations. I'm arguing, people can push back in the discussion section, but I think that we should also be developing physicians who care about who take a systems approach and are thinking not only about their individual encounter, but in some way playing a leadership role in transforming their organizations. And that means also having some responsibilities for population health and community health. And one of the big ethical tensions, I think, over the next, as we make this transition, will be how healthcare professionals, and especially physicians, given how they've been trained, manage the tension between their fiduciary responsibility to the patient in front of them and still play a leadership role in evolving their system to do a better job of community and population level health. We could talk for an hour just about that. So there's a shift going on. I think Rich was right to say that it really began with a push from the Institute of Medicine in 2007. They said, we must quicken our efforts to position evidence development and evidence application as an outgrowth of clinical care. And that is when they first termed the phrase learning health systems. Learning health systems use a variety of different kinds of research methods. They can be observational studies, it can be creation of registries, it can be more traditional clinical trials where you randomize patients to receive one kind of say hypertension management protocol versus another kind. It's a wide range. It's not, a learning health system engages all kinds of research methods. But the thing that they have in common are that they are collecting patient data at the point of care. So patients are both patients and, in a sense, research participants. That learning health systems are collecting information about provider behavior. How did the doctor in this arm remind you about your hypertension medicine, and versus what was used here maybe was a computer system rather than something face-to-face. Learning health systems identify patterns of care and associate those patterns with outcomes, and they collect administrative data. But no matter what the type of research is, the through line of all this is to build an evidence base for improving care. And the IOM, if you're more curious about this, the Institute of Medicine on the National Academies of Science website, where its publications are archived, has numerous reports on how healthcare leaders can manage this transition. And at the end of my remarks, I'm going to share with you some of the things that we learned at the Association of American Medical Colleges about how leaders are doing this. But first, I want to take up Rich's charge and say, what's the moral mandate here? Why is this an important thing to do? And I think it's pretty straightforward. Quality. The US spends almost double on healthcare delivery, and yet our outcomes are not better, and in a few places they are much worse. I've already talked about safety. Obviously, there have been important improvements, and especially in particular areas, we've seen dramatic improvements, but overall the error rate is still of great concern. I would add to that concerns about disparities. One reason, particularly in a culturally diverse community like this, one reason to want to transform to being a learning health system is to look more closely at the inequities in care, in access to care, and in health outcomes for one's own community. And that would be a very good reason to design studies that looked at that. And then what I think is an egregious, Rich called it a sin, an egregious failure to scale up things we already know work. The old saw is that it takes 17 years from the time you've learned something works to the time that you can actually say it's been integrated into practice. There's been studies that demonstrate that. And I was actually recruited to the Association of American Medical Colleges before I took my position at the Hastings Center because the AAMC was really concerned about that 17-year lag and wanted to help academic medical centers find ways to bring knowledge into practice much, much faster. And then, of course, cost. So it's true that recently the rate of increase in healthcare costs has softened a little bit. That's true. But 2 points I wanted to make about this. First, this is just evidence for what I said a moment ago, the claim I made a moment ago that we spend almost double, not quite, other developed nations overall per capita. And our outcomes are not better. But also, the percentage of our GNP is astounding. Right now, it's 18%, and it's estimated that it's going to be 20% by 2018, even with this lowered rate of growth. Now, cost isn't just a problem for our economy. I think that the high cost of healthcare is a moral problem, and I'm going to give some reasons. One is it is squeezing out what we could spend in other sectors of our society that have an equally important, maybe even greater claim on our dollars, on public dollars. And so, for example, we're underspending on education. Actually, education is a bigger predictor of health status than healthcare delivery. It's squeezing out the environment so that we're not paying attention to the ways in which we can manage these big storms that we're getting and all the other consequences of sea rise. And it's squeezing out physical infrastructure so that our roads and bridges are literally collapsing. Now, the extent to which we're underinvesting in education also raises the moral problem of intergenerational equity, because if our kids are not being well educated, they're not going to have the social and intellectual capital they need to flourish. So there's an intergenerational equity issue here. And we're not only kind of robbing them of that capital that they should have for flourishing, but we're going to load them with the costs of doing all those things I just named that we're not doing. So this disproportionate focus on healthcare costs has real moral implications. And the hope is that as we develop more evidence, we can be more parsimonious, we can reduce waste, we can rein in costs, and we can deliver higher quality and safer care. That's the hope. Another reason reducing healthcare costs has a moral dimension is it's not just all these societal things I just named, but the sad fact is that even if you're insured, if you or a family member gets seriously ill, it's going to be a huge consequence on the family pocketbook. One of the major causes of bankruptcy in the United States is illness that people had to pay out of, either out of pocket because they weren't insured, but even people with insurance can become bankrupted by illness. So there's an argument both from justice and from compassion to say we've got to look at costs. Now, I feel very optimistic. I think that we could be at a tipping point, and I want to say why. First of all, there's a lot of exemplars. The Veterans Administration has done a fantastic job. They are a learning health system. They capture data regularly on patient diagnoses, treatments, and outcomes, and also on provider behaviors, and they figure out which kinds of protocols have the best results. So the VA, in a way, is a tremendous exemplar. Of course, we have integrated health systems like Kaiser and Mayo that have been leading the way on this. And in 2010, the Association of American Medical Colleges made it a priority to try to help build this capacity in more institutions around the country. And that was my major responsibility when I was there. And I was able to identify 75 chief medical officers and vice presidents for quality and safety at 75 different institutions. I learned about your own John Spertus. I don't know if John's here, I'll just embarrass him for a second. But in that process, I learned about leaders like John Spertus who are doing outcomes research to try to improve care at their own institutions. And when I was there, we found 75 such leaders, and we created a learning community among these leaders. We called it the Research on Care community. I think I have a slide from that brochure, yeah. And the AAMC continues to support them through webinars and other kinds of learning activities to help them share what they learn about becoming such systems. And I started to learn a lot of things from these people about what they were doing to make this transition. So I thought I would share with you a few of the early lessons. First of all, one of the things that they talked a lot about, this was true for academic medical centers in particular, that they often had really great health services researchers over here somewhere, and then clinicians in the hospital over here, and that there wasn't a way to link these people together. So yes, there were quality improvement people, but they were in the hospital, and they didn't necessarily have the same experience or even the same permission, even the time, and also didn't have the statistical skills, perhaps, to do what they were doing in a more rigorous way. So a lot of the leading organizations that were first making this transition found ways to bring their in-house researchers who were together with their clinicians and their quality improvement people. And that might sound like a simple thing. It isn't, and it's really transformative to do that. And there's two reasons to do it. First of all, so that the new research can be done on the patient population. And secondly, so that prior findings if you have researchers at your own institution who are doing studies that are externally funded and published in the peer-reviewed literature, it doesn't necessarily mean that what your own researchers are finding is actually going to be made applied in the healthcare system where they work. And one of the people that I interviewed for this study put it this way. He said one of our investigators it was an ARC-funded evidence-based practice center that they had at their institution. We had this center here, and this person was the main person who did the data review on the most recent mammography guidelines. Remember that when they came out, it was kind of controversial. And yet when we looked at our own practice, we said, are we using the research that she helped to generate? And the answer was no. We didn't have consistency of mammography guidelines across our various disciplines in place, and over time, we want to study that. So that's another thing that happens when the researchers and the clinicians can get together. I'm happy to share this afterwards. In the interest of time, I'm not going to name all of the lessons learned, but a few highlights. They often created structures for coming together annually and discussing which studies they wanted to support and where did it look like there were gaps or areas for improvement. And they made decisions as a group. And again, Rich talked about culture. That creates an evidence-based culture. They found creative ways to involve the patients and community organizations. Once a study was done, again, the culture said, it's not just about publishing this, it's about using it. And so they created committees that would actually study the findings and say, how can we apply them? And then when they found worthy ones, they paid attention to how we could actually integrate it here. And then the leadership did several things. They endorsed evidence-based medicine, which by itself is a statement. They recruited researchers if they needed them, which means they put money in. They gave release time to clinicians. They allowed such studies to count towards merit and promotion. I was on a committee at Harvard that has just drafted new guidelines for clinical researchers in the hospitals who do this kind of research, for that to count, because typically it wasn't the sort of thing that counted for advancement. That's a culture change too. And they documented return on investment. They looked at cost, and then that would give them ammunition for the fact that we're doing this in a way, we're looking at quality and cost together, not just one or the other. So those are some highlights. Now, undoubtedly, a lot of these changes are happening because there's impassioned visionaries who want to improve our health system and make it be as safe as the airline industry. But also it would be really naive not to mention that there are external things that are pushing this. And one is the new payment reforms that are coming through the Affordable Care Act. I think I'm over my time, but I'm just going to take if I can take just a minute or two to wrap this up. So one is these new payment reforms, which are flipping the incentives, right? Trying to move us away from fee-for-service, where the incentive is for more over-treatment, towards a capitated system where health organizations are given a fixed amount of money for a given population, which incentivizes you to pay more attention to cost and less driven by over-treatment. So that's going on. So these healthcare systems are being led by visionary leaders, but also practical leaders who realize their organizations may be at financial risk if they don't do a better job of this. So that's an external thing that's moving this along. And the other factor that's moving it along is that the Affordable Care Act created a quasi-governmental institute called the Patient-Centered Outcomes Research Institute. How many of you have heard of this? $500 million budget a year through 2019, at which time it may be sunsetted, so it's time sensitive. But adding $500 million in available grant money to do this kind of research doesn't hurt. So those are all things that are pushing it in the right direction. What might hold it back? My biggest concern is that Congress has mandated that the kind of research that's coming out of PCORI not be used to make coverage or reimbursement decisions for Medicare. Can you believe that? We're just going to do all this, but CMS shouldn't use this to set reimbursement rates or coverage decisions. An earlier version of the Affordable Care Act did, of course, include that, but Congress insisted that it come out. And equally distressing, PCORI, with its $500 million annual budget, has been forbidden from reimbursing grantees for collecting cost data. So if you get a PCORI grant, please collect cost data, but you'll have to pay for it yourself. You can, you're allowed to it, of course. The government can't, oh, it's not even the government, it's a quasi-governmental institute, but you can't be stopped from measuring it. But you can't put the time and personnel costs that go into collecting it onto your grant. This is an example of the turbulent history the United States has had when it comes both to clinical comparative effectiveness research and especially cost effectiveness research. I don't have the time to describe that history, but I just want to end by reminding people that we have never had any traction in the United States for creating technology assessment. There are important institutional capacities in technology assessment in the UK, in France, in Germany, and in Canada. But here, criticism from the pharmaceutical and device industry has worked against cost effectiveness because they're afraid that it might determine that one of their products is inferior, that they've invested a great deal in. We have the agency, we had an earlier version of an agency. The earlier version was called the Agency for Healthcare Policy and Research, and it was almost shut down because physicians were distressed that it had discovered that some surgeries that they routinely did were not effective. And then, of course, we have politicians who are constantly raising the specter of the R word, rationing. So we have a lot of pressure against a movement that I think is advancing, but it's advancing in this difficult context. So I think the great irony is that in the United States, the most promising route for enhancing quality, safety, reducing disparities, and getting a handle on cost, the most promising route actually may be at the local level, where leaders like you could just say, we're gonna try to fix this. We're gonna be responsible professionals, and we're gonna show leadership and try to do this ourselves. So that's the charge, in a way, that I leave with you, and the hope that this is something that will get picked up by leading healthcare systems, and that we will just do it regardless of a very challenging context. And I guess that's why my last slide is of my son on the top of a mountain, because I do want to leave him someplace where he'll be able to scale these mountains, and he'll have the resources, and he will not be disadvantaged. His generation won't be disadvantaged in the ways that I think we are on the verge of doing for them. Okay.